The first annual Riordan IVC and Cancer Symposium presents the Riordan IVC Protocol Dialogue with Practitioners. Your presenter, Ron Hunninghake, MD.
Safety for the patient. I think that has to be our #1 priority. Then there's safety for ourselves from a legal perspective. And if we have established protocols that make safety the #1 issue, that's good for everyone. One of the possible complications is that if your patient is a type 1 insulin-dependent diabetic and you happen to do a glucometer test on them, not knowing that there is a cross-reaction between the ascorbate and the glucose on the glucometer, you may think that they need some insulin because you might get a reading of 250 or something like that. And you might decide to give them a bolus of insulin, not knowing that in reality this is a false reading. And you could put them into insulin shock, as we found out one doctor did to his wife, which is not a good person to do to. So anyway, that's why we put this in red. We hope all of you have a real clear understanding of that. If you do, Dr. Jackson will be talking a little bit about this afternoon, but if you do your typical laboratory glucose level, you'll find that the level does not go up. So it truly is a false reading. So do not pay any attention to glucometer readings. It does raise an interesting question about a simple means of following the vitamin C level, and Dr. Jackson's actually working on that now. There is an introduction. Most of the points in the introduction we have already covered this morning. The treatment rationale. The one point that I would like to draw to your attention, and you'll notice that this is written with numbered points in each section, so it is like a protocol. And if you have comments that you want to make to us about the protocol in terms of your own experience, it's very helpful to say point number 6 in the introduction or point number 3 in the treatment rationale. It kind of helps us communicate a little bit better. But you'll notice that what we try to achieve here at the center is a post-vitamin C saturation level of about 350 to 400. And the idea of that was we needed some way of attempting to follow our cancer patients and to look at the effectiveness of the dosages that we were giving them. And I think that's going to be a theme that we'll be hearing about as the symposium progresses. If you go to page 2, you'll kind of see where we came up with that number. Based upon the early studies in cell culture, you can see that in various types of cancer cells, that as you increase the dosage in the culture medium, that's where you start getting the cytotoxic effect, and it's somewhere around 350 to 400, and obviously it varies with the different cell types, but we chose that as just a general target for our patients to shoot for. The next figure down, figure 2, basically shows you that when this is growing on a very sparse monolayer, it didn't take as much vitamin C. It took more if it was a dense monolayer of tumor cells. And then in the hollow fiber cells, which simulates a tumor, it took much more. And so we still are encouraging our patients to somehow debulk their tumor if they can, unless they are just violently opposed to that. We're still promoting IVC as adjunctive therapy for this very reason, that large tumors may or may not respond for the fact that it may not be absorbing adequately into the inner parts of the tumor. And then on figure 3, this was the prostate cancer gentleman that Neil talked about. At least the first patient 1 was, and it just kind of gives you a picture of some of the pharmacodynamic studies that we've done here at the center, and getting an idea that different people peak at different levels depending upon how many infusions you've given them. Very often when people start out, they'll start out with very low post-IVC saturation levels. The rest of this page kind of goes more into some of the mechanisms. Moving on to page number 4, we have some inclusion criteria that kind of can help you decide who, the rationale for why you're letting people into this. And I think this will be helpful in terms of delineating different types of protocols, different types of patients in a IVC protocol. It's also the part that deals with safety. If you do a very good workup on these patients, you're protecting them and you're protecting you. And also, in terms of further research, Dr. Hyland has made this point number 4. If you can do really good tumor typing and staging and get all your reports in hand, then down the road, if you have a really successful cancer patient, you can avoid that the doctor saying, well, it was just a spontaneous remission. And of course, I tell people we're in the business of inducing spontaneous remissions, and that's what we always hope for with our patients, with a little help from nutrition and some of these modalities. The precautions and side effects we've pretty much discussed. Dr. Jackson will go in detail on the issue of G6PD. Nurse Marcia McCrae will talk a little bit about some of the nursing issues that go along with that tomorrow morning. We have calculated the osmolalities of the standard dosages that we use. That has been a concern for us, is that some of the practitioners around the country are using very high osmolality doses, and we're a little concerned about the effects of that upon patients. And some of the patients that you see that have either painful infusions or headaches or nausea or some kind of distress, not feeling well, oftentimes dizziness, it's oftentimes an osmolality issue. Certainly it could be a drop in calcium or a drop in their blood sugar, but it could also be an osmolality issue. And so we've taken the time to not only calculate the osmolalities, but we've actually measured the osmolalities, and that data is available from our lab through Dr. Jackson. And then on page 6 of the protocol, the administration of the IVC, because we traditionally started with a 15-gram infusion, that's the way we start with our patients. We feel very comfortable with that. Our nursing staff is comfortable. Patients generally tolerate it very well. It's surprising. There are some patients that do feel very ill, though, even after a 15-gram. And I'm a little concerned when people say, well, I'm just going to jump in there with 50 or 75. I know that Dr. Driscoll was defending a case out east of a patient with cancer that just received a 25-gram, which, you know, most of us would say that's not very much, really. But she ended up in hemolysis, and unfortunately the practitioner had not done a G6PD. So from a legal standpoint, I think it's good if you can do that. You're protecting yourself. You're also protecting the evolution of this particular therapy. And so, well, again, we do post-IV saturation levels at the 15, 25, and 50-gram range on 3 consecutive days. And we can kind of plot those 3 points on the curve and get a pretty good idea of what dosage this patient is going to need in terms of a more effective dosage range. And you can go through the details of this. The concurrent therapy, Dr. Hyland will be discussing some of the issues in concurrent therapy in his talk right after lunch, where we talk about the compatibility of IV vitamin C with conventional therapies. I will just quickly take you, before we start the panel, I'm going to take you, now if you go back to your syllabus where it's listing my talk, I'm not going to go through these because it looks like we're not going to have enough time. But these are it's a paper entitled The 12 Insights, or What Really Causes Cancer, 12 Insights. And basically, again, I apologize that we don't have enough time, but this was my attempt to look at what I saw as the 12 steps that occur in the process of people getting cancer, and I think different researchers will and presenters in the course of the conference will be discussing these points. Dr. Xiaolong is going to talk about cytokine levels. Dr. Sullivan's presentation, out in the Taste of Health, goes over St. Gorgie's discussion of electron flow, and I think Dr. Levy is going to be discussing that night in the keynote speech. On the second page, page 4, or steps 4, 5, and 6, this is actually, this is a very eclectic kind of presentation of the various ideas as what causes cancer, what can we do, how does the IV vitamin C help this out. To me, the really interesting thing is the anaerobic metabolism and the loss of mitochondrial function. No longer the cell is making 36 ATPs per glucose molecule, only 2. And so those sodium pumps are no longer working properly. You can't get oxygen into the cell because no carbon dioxide is coming out, or very little is coming out. And so the cell goes anaerobic. And part of what we think vitamin C does is to start reestablishing that anaerobic, or this aerobic metabolism, which is the basis of apoptosis. The p53 gene basically sends a signal to the mitochondria to self-destruct, and if your mitochondria is not working, you're not making enough reactive oxidative species to fuel the apoptotic mechanism. And one of my concerns about the ultra-high doses of IV vitamin C, if we give so much that we knock out this particular mechanism, if we cause a kind of disruption of the p53 function, then we can no longer induce apoptosis, and we now have tumor resistance in the same way that patients on high-dose chemotherapy can develop tumor resistance. So there's this question of what is the right dose for the right patient, to me, is a very key question that I'm hoping that we can get some insights at this particular symposium. On step number 9, we took about 15 of our cancer patients, and looking at the supportive information, this was the immediate post IVC ascorbate level after a 15 gram. The first column is a healthy bunch of patients. The second one is stage 1 type patients. The third was regional spread, and the fourth one was the people who had distant metastases, stage 3 and 4. And you can see that as the cancer progresses, there's much more inflammation, more oxidative stress, and a higher level of vitamin C is being needed to neutralize the oxidative stress that those patients are under. And finally, on the last page, we're talking about how the patients that if their cells are damaged enough, they have what Dr. Neil Riordan and Xiaolong Ming have described as the non-healing wound, and there's some discussion there of why other nutrients may be important in helping the cell to reestablish normal function again. This was actually Dr. Roger Williams' basic idea that cancer is the loss of the multicellular organization and the control mechanisms that keeps cells working as individuals that are part of a community of cells, the body. Whereas the cancer cell becomes, as Stephen Hickey has called it, the selfish cell, where it has regressed back into a single type of cell that is only striving to survive and paradoxically contributes to the demise of the organism. So with that little prelude, I'm going to invite Neil and Jorge and Michael to come up and sit on our panel. And we have our microphones here, and I'd like for all of you that have questions of any of the speakers this morning to either come to the microphone, or I've got your questions here. If there are any other questions, the proctors will pick up your cards, and we'll see if we can help you get a better idea of what's going on here. And I'm just going to kind of start this out while things are getting going here. I'm just curious, based upon the three presenters this morning, Neil, do you guys think that higher doses of vitamin C is the answer to patients who are not getting well, cancer patients who are not getting well?
Well, when you say higher doses, how
Microphone. Oh, you got it. Now you got it.
when you say higher doses, how high are you talking?
75, 100, 125.
Well, I think clinically, you don't really need to go that high myself. That's my personal opinion. But based on, we used to have the Aiden Clinic, and we had the Bahamas, and we treated thousands of patients. And you know, in some cases, you go up high and, like, I remember a guy with lung cancer. He was, you know, he's a big guy with lung cancer, and we actually gave him 75 grams twice a day for some period of time, and he had an amazing response. But normally we give typically no more than 50 grams per day for a larger person, and then 25 grams for a smaller person. And I've seen other people given, I don't know, 200 grams a day and that sort of thing. And we had some patients where we gave them really, really high doses, and I didn't think clinically they did much better than. In fact, I know in one case, I suspect the guy did worse than he would have if he'd got a lower dose.
Okay, go ahead, sir.
I do IPT, and my question to the panel is, I have tried giving insulin before using ascorbic acid, and we have great success on that. I just want your opinion on that. What do you think?
We really want to take a look into that, and we believe it's something that might give us a better response. We don't know it for fact, but if you had results, we really, before even knowing that you've been doing it, where are you working?
I work with Dr. Stephen Ayer in Chicago, and basically I'm an ER and a family physician, but I do IPT with low-dose chemo. And with low-dose chemo, we basically use insulin as a modulator to lower down the sugar. And I was looking into also using, because we use high-dose chemo, high-dose ascorbic acid after the chemo treatment. And the patients are responding very well when they are given insulin before even given the ascorbic acid.
You see, I think we can add both previous questions, the dose, how much of the dose, and this one, because I had to agree with Neil that not necessarily you need like the highest doses to treat cancer with everybody, because for one thing, even though we believe cancer is the same disease, it's just in different tissues and different levels of differentiation. The real thing is that not all cancer cells will respond the same. And since there are so many mechanisms of actions that will take place during the treatment, you might have moderate concentration that will affect the particular mechanism that would be most effective in that particular. So it's quite complex. We need to do more research in order to understand this better and be able to design the best dosing regimens. Now, what you're bringing is exactly the reason we wanted to research this, is because we know insulin will activate this GLUT transporter and most likely will allow more vitamin C to go in, and theoretically that will make it more effective. So that's why we want to do that.
As a
I just wanted to
okay,
address the question that you made to Neil. In our experience with hundreds of patients, he has thousands. So it's the same as Neil. I concur with Neil that we don't need that huge of a doses. We had our most successes has been with 50 grams. Okay. So in terms of the insulin question, we want to look into that.
Yeah.
But it's a pain in the ass, insulin. So so in that sense, but it's something valid because we might be able to even reduce further the dose with the insulin. So
In the higher dose patients, the ones that seem to do better on the higher dose, the ones that have a whole bunch of disease, and then after they have less disease, and you can taper it down, and they tend to do well. That's been my observation. And then if you look back at those historical early cases from the center where they didn't receive, you know, you actually had absolute home runs where they did not receive more than 30 or 50 grams.
Well, and even the very first set of research, you know, Pauling only gave 10 grams once a day, IV, for 10 days, and then he followed it up with oral. Do you know if that oral was in divided doses or was it a single dose? I don't think it's not in his literature. Not knowing.
It's not in the literature, but as I saw him in Oklahoma, he took it in divided doses. He himself
took it in divided doses. Yeah, a lot of these questions. I want to get to back to the microphones, but a lot of these questions here have to do with lipoic acid, and to kind of follow up on the whole insulin potentiation. should we be giving a little bit of lipoic acid prior to IV vitamin C in order to get the insulin potentiation and to lower the cytotoxic dose needed with the IV vitamin C?
Yeah, well, I think, go ahead.
Go ahead. We always do it. We always not
IV or oral?
Right now it's oral, and we could do IV, I guess. Yeah, I don't know if it will make a difference because of the effects of oral being so good. Somebody has to look into that. Yeah. However, we always do it, and not just lipoic. We also add coenzyme Q10, acetyl L-carnitine, and always try to have a B complex of magnesium so that all the proper substrates to induce mitochondrial function will be there.
What doses do you use?
Lipoic acid, we want to recommend something like 300 milligrams twice a day, especially of the R form.
I did ask Dr. Kasari before the conference that what dose did he use in that experiment that was published in the British Journal, and it was 10 milligrams per kilogram. So that'd be around 700 milligrams per day.
Right, and the one cautionary note on alpha lipoic acid is that if you go to higher doses, there was a clinical trial that was done that was started by Asta Pharmaceuticals. They have in Germany an IV form, and I don't know if there's an IV form here.
Yeah, there is.
Yeah.
Mm-hmm.
There is.
Bert Bergson uses it a lot.
Approved, or is it
Bert Bergson
compounded?
uses it a lot. I don't know.
Compound.
Compounded. And
McGuff.
oh, McGuff. Okay. Well, at I think it was around 1,600 milligrams. Though it wasn't a human trial, it was a monkey trial. They were, gearing up because they had to do large animals before they got approved. And at 1,600 milligrams equivalent weight for a human, their livers started to dissolve. So I wouldn't go much past, 600 milligrams a day, or certainly in a single infusion.
Yeah,
I wouldn't go above it.
And Dr. Kasari told me that he did some studies with 100 gram per kilogram per day lipoic acid on the rats, and they died. So yeah, I think I'd go along with you.
Now, if people are going to be using IV lipoic acid, they have to watch for glucose, because it can go down and it could be a problem. However, at this point, I'd like to hear some other people talking about this. At this point, I'm not sure if it's important to have IV unless you have people who might have difficulties with oral dosing. We're currently recommending the use of 300 milligrams 2 times a day of the R form.
CoQ10 and L-carnitine?
Oh, the CoQ10, we're recommending ubiquinol, the active form, although Michael thinks it wouldn't hurt to add the ubiquinol, the original form, to have both forms in the body. And we don't really know what would be the optimal dosing. However, we're recommending around 300 milligrams a day, 200 to 300 a day. And acetyl L-carnitine, 500 milligrams once or twice a day, along with enough B complex. We haven't stated formally how long before the infusion. That's something we should be discussing. Some people say that if you are to take lipoic acid, you'd rather have it with empty stomach. Some people disagree. So that's something we need to really discuss. We don't know.
Have any experience or an opinion about using intravenous DMSO as an adjunct with vitamin C?
I don't know.
We've not studied it. I know it's being used in different clinics, but we've not studied it here. It may have something to do with improving oxygenation of the cancer cell, but it's still not anything that we've done much of with here. So, sorry.
We've used it in different scenarios. In people with heavy metal intoxication, it worked wonderful, but I can't tell you in terms of cancer.
Yes, sir.
I'd like to
There you go.
I'd like to find out if there is much experience with guidance of using this with chemotherapy as to timing. Should it be used before, during, after? And I do understand about the concept of the pulsing being important and not have a constant saturation.
Well, we've had patients using it, and we have seen that the use of the IVC and oral nutrients before, time before starting chemo will allow the patient to sustain a lot more energy and lower side effects, the level of side effects. So we rather prepare the patient for the chemotherapy rather than to react once it had been given. And when you look to the Prasad study by Prasad, it seems like that holds, like a mechanism.
Are you seeing a change in outcome from the chemotherapy as to a higher treatment rate, or are you finding any change on the opposite side?
We had a couple patients in experimental chemotherapeutic protocols, and the only patients that resisted the experimental protocols were the ones that were given the supplementation and the IVC. So it made them, resist better the experimental protocol. They responded very well. They're still cancer-free. So I think it was a valuable thing because it kind of permitted the effectiveness of whatever that therapy was, and it decreased the side effects, and it permitted them to finish actually the treatment.
Dr. Hyland will be discussing this after lunch, and also you can talk with Dr. Sullivan, who is the partner with Dr. Driscoll. We've been waiting for her study where they gave IVC as part of the prehydration IV for chemotherapy. So that'll give some information to that.
Thank you.
They did it on the same day?
Yeah.
Well, our general rule here was always to, if you look at the PK curve of IV vitamin C and it goes way up and then it tails off post-IV, at 24 hours later you're basically back to baseline. So our rule of thumb here was give it whenever you can because of logistics and that sort of thing, but give it 24 hours away from the chemotherapy. Yeah. And I'll just tell you about one case that we had here that sticks out in my mind about a patient with colon cancer, who had liver mets and omental mets and duodenum mets from primary liver cancer. And he was on 5-FU leucovorin weekly, and he came here, and initially we gave him 50 grams twice a week, and we actually raised him up to 100 grams twice a week. And while he was doing the 5-FU leucovorin, he was a very large man, though, I will say, and he never achieved a plasma level even with 100 grams over, say, 250 milligrams per deciliter. So we never got into real toxicity ranges, cytotoxic ranges with him, but he was here the entire time until I left. I don't even know what happened to him follow-up wise, but he was alive and well like 2 years later. And as long as he stayed on the vitamin C, he really had no side effects from the 5-FU. When he went to Florida for 2 weeks. He didn't get his vitamin C, but he did see an oncologist, and he got his weekly 5-FUs, and he did start getting side effects. And then when he came back, he started getting IVs again.
We have another patient exactly like that, is now a 7-year survivor with no cancer, stage 4 colon cancer with mets to the liver and the peritoneum, doing very well. And she's still getting her 5-FU once a week, plus her IVCs a couple times a month.
Ron, there's something that I like to say that I think is especially important in people who are really very, very sick, very compromised, and that life expectancy is very short. If you have a person like that and is receiving IVC and other nutrients and is improving, be very careful with starting them on some other chemotherapeutic chemotherapeutic agent, because those are the people who are high risk for having problems. Okay. Because they might not tolerate the chemo.
I have a couple of questions, but I just want to, part of it is a case I had, and he was a gentleman that had 80% of his bone marrow was affected by like myeloma. And when he came in to see me, his white count was like 2.3, and he had 3 abscessed teeth in his mouth. And he said, "What can I do?" So we started doing IV vitamin C and all the other vitamins with it, and his white count came up. So he was able to get all of his teeth fixed. I think he actually removed most of his teeth because they were all in bad shape. And he came back and kept doing 30 grams of vitamin C 3 times a week. But we added mistletoe and thymus. So just wondered, when he got thymus injections, we got the thymus from Europe. I think we used to get it here, but we can't anymore. And he stayed alive for about 6 years, and then he started going downhill, and I think they gave him some IV chemo that had just come into being after. But he was amazing, you know, and he was only getting, he wasn't a big guy though, but he only got 30 grams of vitamin C.
Very interesting, thank you.
Do you ever use thymus though, or to boost the immune system?
We have an oral preparation that we do use, yes.
Because you can get an injectable from Europe now, and I think it's really effective.
Immune help.
Yeah.
It's a good immune helper.
Injectable. Okay.
Okay. Yeah, go ahead, Mike. Yeah.
Okay. I'm really fascinated by this notion that 25 or 50 grams may be plenty on many of the patients. I've been using the vitamin C for cancer patients probably for about 30 years now. Started back, Harold Manor down in Mexico was using a combination of 9 grams of amygdalin, 25 grams of C, and 5 or 10 cc's of DMSO for many years. And we've been using the 25 for many years. And then in the last couple of years, with Jeannie Driscoll commenting about the 350 to 400, I've started routinely now to check the levels. And most of the patients, I have to push up to 90, 100, or 110 grams in order to get to the therapeutic ranges. But I'm not sure clinically that we're getting better responses than we got for 25 to 50. So I'm just really fascinated to hear that maybe you don't need to do that. Of course, your patients are there longer. It costs them more money and so on when they're there. And if the 25 to 50 would do the trick, maybe we don't need to do that. But apparently that's not, the mechanism then is primarily not the cytotoxicity of it. It's other things.
Yeah, I completely agree with you.
We'll keep looking into that.
Actually, my comment is exactly along his lines. Like, I've been using intravenous vitamin C for about 10 years. My practice is strictly cancer-based and up in Vancouver. And when I first started, I was, I didn't know. And I was looking at the work of your father, and I even collaborated, talking about a case with AML using 100 grams of vitamin C. And I found throughout the years the load was just too much for them. So I started using 25 grams of vitamin C IV, and I'm getting like great successes just with that alone. And these are like metastatic melanoma, non-Hodgkin's lymphoma. And but in my protocol though, because I'm always influenced by a bit of the Myers cocktail and other things, so I add like zinc to it and selenium to it, and so I don't know if that helps or not, but that's just been my clinical experience. So hearing your discussion, exactly what he said about using 25 to 50 grams, totally confirms what I've been seeing in my practice, and I don't measure blood levels in that world of things, and so I just wanted to share that to the group.
May I ask you, what rate of infusion do you use?
We do it in the span of about an hour and a half.
Okay, so about 500 milligrams a minute?
Yeah.
Okay.
I have to say, like, these two last comments, I guess go to the point of what we need to be doing, sharing information about what we're doing and the results, because that's the way we improve therapy. We'll take that information, we'll do more research, and we'll refine what we know. We believe the protocol will be improved by having more information on what are the doses, but not just that. What are the things we need to add, like the calcium, the magnesium, the lipoic, and so on?
Yeah, it's a really difficult sell. It's so intuitive to want to give more is better. And we were, myself and, were you there, Michael, the cancer treatment centers? The CTRF?
Yeah, he was there. I was there.
Yeah, several of us were invited to this when they were planning their clinical trial. That I think Jorge put something about it up there. They haven't released the results yet. But there were a couple of us clinically, and one of the doctors that used to work for me, Aiden Clinic, and we had come to this conclusion a long time ago that the big doses for the majority of patients just weren't doing it. And we had a very different, we basically did not convince them that 50 grams is enough.
They
did not convince them, and they actually were talking about doing 100, 200 grams
Let me tell you that
on each patient. And then what did they wind up doing? Because you had the data there.
They did increasing dose, and even though the results haven't come yet,
They don't seem to be that great.
They don't seem to be that great.
I see.
The point is that in terms of dosing, I think what Neil says, we're totally concur with him, but in terms of cancer, it seems to be, we have pretty much success with the 50 grams, but in terms of infections, we probably need the higher doses for infections, but that's another story. What I wanted to add was that this, when you flow the body with too much vitamin C, it seems to, what Jorge described as systemic saturation, and it seems to overwhelm the body to try to get rid of it instead of taking care of what it has to take care of. So I think that's one of the big issues there.
Well, there are a couple examples. You know, Cathcart wrote a few articles about, you know, bowel tolerance and that going way up in different situations, particularly in viral diseases, which I thought was just genius, you know, and it tells you kind of where you need to be. And I don't think bowel tolerance is a real bad idea for cancer patients either, just to find out how much they need, you know. And
That's not IV.
yeah, it's oral, but it's kind of giving you a guideline because, you know, I remember Dad had this patient who was he owned a company that did crop spraying, aerial crop spraying.
Oh yeah.
And he got sick, you know. He used to mix all the chemicals and stuff, and he got so sick. He got so sick he couldn't fly anymore, so he owned the company, but he spotted the plane. So they come and overspray him, right? Oh my God. And so Dad told him to take, I don't know, so many per hour and just keep raising it until you get diarrhea. And he came back a week later and he said he still hadn't gone to the bathroom, and he's up to 100 grams a day.
Oh orally.
And then he comes back 3 days later and goes, Doc, I finally did it. So, you know, that's a guy that was really sick and he required a lot, and he was just doing it orally.
I think we could go on, but I'm afraid we're going to have to eat some. Who's hungry in here? Yeah, I know you're hungry for knowledge too, but I think we better. Well, go ahead and write your questions down and come up if you want to talk just for a minute here.
Hey, you know what? Can I do something real quick?
Oh, Neil,
on your computer? I'm just going to tell you, in case anybody wants to write this down, I'm going to put up on the computer here my. I put my dissertation up on the web. I have a private website. And I don't have the piece of paper, but I think I can remember it. I'll just put it up here on a slide. Is that okay, Dr. Ron?
Yeah.
Just hit new slide and I'll. Okay. So anyway, it'll be up here during lunch, so you don't have to wait now. But I'll put it up here. HTTP. What is it? Colon slash? Thank you, Professor. Let's see, stem no, it's no W there. Stem cells .editme.com, and then it's under /research. And about halfway down the page, you'll see a little hyperlink that says Riordan dissertation, and if you click on it, it'll just open it, and then you can save it on your computer. And this little thing has been so cool for me because I can just put all my junk up there and I'm organized and I know where stuff is. So.
All right. Thank you very much.
The first annual Riordan IVC and Cancer Symposium was brought to you by the Center for the Improvement of Human Functioning International, located at 3100 North Hillside, Wichita, Kansas, USA. To learn more about the center and what we have to offer, please visit us on the web at www.brightspot.org.